Is this a stupid video topic? I don't think so. As a physio, I've seen many PTs and gym trainers skip the warm-up or not do it justice. That's a shame because the warm-ups are essential for all patients regardless of age or fitness level. Early in my career, I thought warm-ups were only for athletes. I soon realized that's a myth. By scaling active range of motion from gentle movements to more intense exercises, we can tailor our approach to each patient's needs. That's why I created this video, to explore the physio context of active range of motion warm-ups and why they matter for everyone, from nursing home patients to fitness fanatics. This is where some scoff, I'm blending the warm-up with the workout, but you know what? Your body doesn't care what you call things, it's just happy to move. But this video isn't just another warm-up video routine from YouTube promising to transform your life. Instead, I want to give you a context. I want to help you understand the principles behind active range of motion warm-up exercises so you can create your own or critically evaluate someone else's. And yes, I will show you my favorites. In the physio and fitness world, warm-up means different things to different people. For example, sitting in a sauna is a poor warm-up because it's passive, lacking active motion needed to prepare the tissues and nervous system. A stationary bike or a treadmill jogging is only slightly better, unless you're actually going for a bike ride or going out for a run. And then static stretching is not a good warm-up either. Static stretching belongs at the end of your workout. In contrast, active range of motion stands out as the best warm-up. It works for all phases of rehab and fitness levels, whether your patient is recovering from a wrist fracture or your neighbor is pumping iron. Active motion means their nervous system is involved and in control. Plus, active range of motion can be tailored to individual needs, scaling from simple movements like a partial grip squeeze for your wrist fracture patient to whole body drills like burpees for your friend pumping iron. Scaling here also means adding balance component as needed, like progressing from seated to standing to single leg balance. What's more, this approach allows patients to control the speed, amplitude, and range of motion, ensuring a personalized and effective warm-up. And this active range of motion may be their workout if they're early in the rehab process. But everyone needs active range of motion. When I was in physio school, we learned progressing from passive range of motion to active assistive range of motion and finally to active range of motion. That's when it clicked in that all these warm-ups, dynamic warm-ups, movement prep, controlled articular rotations, these CARs, are essentially active range of motion in different flavors. The terminology might sound different, but the underlying principle is the same. Different coaches, trainers, and therapists may use different names, but it's all about active range of motion. These various approaches may be different in their intensity, specificity, or location, but they all aim to get the patient moving through a pain-free range of motion. Rather than getting bogged down in all these definitions, let's focus on the underlying principle. Active range of motion is king. If you do a Google image search on these terms, you'll see a lot of the same movements. We'll talk about how to make sense of it all. In this video, I'll give you a context to go from recovery to gym fitness for this active range of motion, because rehab to fitness is a continuum. And I'll start here with the active range of motion across my simplified treatment phases. Section 1, using active range of motion dynamic warm-ups in each physio treatment phase. Let's break down the 3 treatment phases from my simplified approach to physio so you can take the bull by the horns. This makes it easier to navigate your patient's rehab journey with setbacks and detours and speed bumps. That was this video here if you want more details. But to refresh your memory, start with pain management, progress to recovery of motion, and finish with strength, balance, and mobility. Our goal is to progress every patient to strength, balance, and mobility. This is the fitness finish line where rehab transitions into wellness and fitness. Active range of motion is key to navigate these phases. Let's dive in and explore how to apply this framework in practice. Pain management phase, gentle exercises to start with. In the pain management phase, we use gentle, pain-free, active range of motion exercises to keep joints and tissues loose without making things worse. Your goal here is to maintain mobility. We also make sure to include exercises that target the joints above and below the injury site. This helps reduce stiffness and promote circulation and support an overall healing process. For example, if someone has a painful knee, gentle exercises like pain-free ankle pumps and log rolls for hip rotation can be done in the physio setting. For a higher functioning patient, such as somebody at the gym, exercises like mini squats and calf raises, hip swings can be done while still managing those knee pain niggles. Similarly, for a patient with shoulder pain, exercises like pain-free elbow flexion and extension, some pronation supination, open hand, closed hand, Codman's circumduction of the shoulder can be done in the physio setting. For a higher functioning patient, Patients can use horizontal abduction adduction with pronation supination, the rest stretch, that's shoulder rotation with open hand, closed hand. This can be done while managing those shoulder pain and niggles. From pain management, we progress to recovery of motion. Active range of motion works here too. In the recovery of motion phase, we start to progressing from active assisted range of motion to active range of motion, scaling motions to suit the patient's needs. As physios, we can also apply our manual therapy skills here. That's passive range of motion idea that we talked about with the continuum of movement. As we work on active range of motion, it's essential to educate patients on pain-free exercises to recover motion and ensure that joints above and below the injury remain mobile. We also need to progress our exercises, gradually increasing range and speed and number of joints involved. Quality is more important than quantity, so we adapt exercises to the patient's ability and needs, emphasizing controlled active range of motion over maximal range, especially in the early stages. Neuromuscular control plays a significant role in regaining motion, so we can expect to see objective improvements with range increasing around 5 to 10 degrees every 4 to 6 weeks. Patients typically remain in this stage until the functional motion is restored. However, if progress plateaus for 4 weeks or more, it's essential to reassess, adjust our approach, ensure that we're getting the best possible outcomes. For example, when treating a stiff hand, you might start with some active assisted finger flexion, progressing to active finger flexion as the patient opens and closes their fist. Further progress can involve incorporating shoulder rotations like the arrest stretch. Another example is hip flexion, where you might begin with heel slides on the table or seated, progressing to supported standing toe tapping exercises, eventually standing zombie kicks. From recovery of motion, we progress to strength, balance, and mobility. And wow, more active range of motion here too. In the strength, balance, mobility phase, we build on the progress made earlier using active range of motion exercises as a dynamic warm-up. You can call this movement prep or controlled articular rotations or whatever. The bottom line is we're using dynamic active range of motion to prepare the body for functional exercises. Dynamic warm-ups are a crucial aspect of this phase, and the evidence supports their effectiveness in improving performance and reducing injury risk. Examples of dynamic warm-ups include leg swings, arm circles, and bodyweight squats. These exercises mimic daily activities and functional tasks, emphasizing pain-free movement and restoring functional loss. As we progress through this phase, we focus on integration techniques that enhance functional capacity. This involves multiplanar neuromuscular control, where exercises focus on stabilization and mobilization and efficient movement patterns. We also incorporate balance exercises, starting with double leg stance, progressing to single leg support. This improves reactive control through the proprioception and vestibular input, helping patients develop balance and stability for their daily activities. For example, when working on sit-to-stay mobility, you might start with an open kinetic chain seated straight leg raise with dorsiflexion as a warm-up. For stair training, supported mini squats with calf raises can serve as an effective warm-up. When focusing on single leg balance, supported leg swings or walking heel-toe can also be useful. For leg strength and endurance, mini lunges and single leg balance like Statue of Liberty exercise can provide dynamic warm-up. These treatment phases are your roadmap to your patient's recovery, and you can see how there is a continuum of active motion throughout the treatment phases, or we can flip this on its head and approach it from the diagnosis side. Remember my 3 simplified physio diagnoses? Let's crack on. Section 2, specific active range of motion dynamic warm-ups in each simplified physio diagnosis. My 3 simplified physio diagnoses are overuse, traumatic, and systemic. You've already seen my video, right? The idea is that your patient's underlying condition impacts how you approach your physio treatment. Within each diagnosis, you use those same 3 treatment phases we just talked about. Remember, they're on a continuum with a goal to get everyone to the strength, balance, and mobility. That's the gym phase. And let's look at each diagnosis and how active range of motion plays its part. When dealing with overuse injuries, it's important to avoid pushing too hard too fast. Sometimes you just have to bite the bullet and take things slow to ensure proper healing. Active range of motion exercises should prioritize controlled low-intensity movements to avoid exacerbating the issue. The primary goal is to build resilience and prevent further irritation. In this context, it's essential to focus on smooth, pain-free movements, minimizing compensations and enhancing proper form. As pain subsides, the patients can gradually introduce more amplitude, speed, and multi-joint motions. Education on load management is also crucial. Patients should understand how to avoid irritating their symptoms during dynamic movements. Gentle, controlled articular rotations within comfortable range are recommended. The emphasis should be on pain-free activity and gradual progression. Avoid pushing through pain, which can lead to setbacks. For example, when treating a patient with tennis elbow, you might start with pain-free motions such as opening and closing the fist, wrist flexion and extension, forearm pronation supination, and elbow flexion and extension. Codman's pendulum swings can also help maintain shoulder mobility. Initially, a band strap brace may be worn during hand activities, or you can teach the patient Mulligan's self-applied mobilization with movement. As the patient progresses, you can introduce active range of motion exercises such as pronation and wrist flexion with a closed fist. Another example is Achilles tendonitis. Treatment might begin with pain-free seated ankle pumps and long arc quads with dorsiflexion. Progression can include supported mini lunges, supported hip swings, and squats to calf raises, and alternating step standing lunges. Now let's turn to the traumatic diagnosis with active range of motion. In the context of traumatic diagnosis, the use of active range of motion is just what you'd expect. This is your motor vehicle accident patients, your slip and falls, post-fracture, post-op patients. Follow the 3 treatment phases I've already outlined. Active range of motion plays a crucial role in the 3 treatment phases. In the initial pain management phase, gentle active range of motion exercises help promote mobility, reduce stiffness, and promote circulation. As the patient progresses to recovery of motion phase, active range of motion exercises become more dynamic, progressing from active assisted to active range of motion exercises and stretches. We can scale these motions to suit each patient's need, emphasizing controlled movements and neuromuscular control. Finally, in the strength, balance, mobility phase, active range of motion exercises serve as dynamic warm-ups, preparing the body for functional exercises. This not only improves performance, but reduces injury risk by incorporating balance exercises and integrating techniques for efficient movement patterns. And strength, balance, and mobility blends into gym fitness after rehab. Remember, continuum? Hold on to your hats because we have a systemic diagnosis, and yep, there's more active range of motion exercises here too. When working with patients who have a systemic diagnosis, incorporating active range of motion exercises into physio requires careful consideration of the underlying condition. This might include conditions like osteoarthritis, rheumatoid arthritis, which involve joint deformities, or heart disease and cancer, which can lead to limited activity tolerance. I've seen many patients with these conditions, as well as those with more general issues like reduced balance or repeat falling. In these cases, the focus is on pain-free activity, safety, and fall prevention. We still need to follow the 3 treatment phases, but it's essential to recognize that exercises won't change the underlying bony deformities. Instead, we prioritize patient education and to reduce irritation and ensure safety. This includes addressing fall prevention strategies such as identifying fall hazards at home, addressing patient-specific fall risks, and adapting functional abilities. Gentle, dynamic, active range of motion movements can help keep patients moving without exacerbating their condition. As patients progress through treatment phases, we focus on pain control, recovery of motion, and eventually strength, balance, and mobility, as much as the symptoms will allow. It's essential to have realistic expectations, recognizing that some patients may experience limited recovery, while others may require ongoing management to slow decline. In either case, we emphasize long-term self-care and empower patients to take an active role in managing their condition. Throughout the treatment process, active range of motion exercises remain a crucial component in emphasizing pain-free activity and aiming to improve or maintain function, while addressing that underlying safety and fall prevention issue. We've discussed the importance of adapting active range of motion exercises to patients with systemic diagnosis. Now let's take a step further and explore how to seamlessly transition our patients from rehab to fitness. It's time to break down the barriers and create a continuum of care. Bonus section, active range of motion dynamic warm-ups blending rehab and fitness. Rehabilitation and fitness exists on a continuum, allowing physios to guide their patients from recovery to lifelong fitness. Active range of motion as a dynamic warm-up are used before more vigorous activities. Movement prep programs should be tailored to individual patient needs, addressing isolated niggles with techniques like controlled articular rotations. Understanding movement progressions is key to bridge that gap between physio and fitness training. Let's take squats, for example. In the rehab setting, we might start with mini squats supported or using body weight, focusing on pain-free motion and control. As patients progress to fitness settings, we can include goblet squats or barbell back squats by increasing the load and focusing on strength and power. But here's the thing, those initial mini squats can still be used as a dynamic warm-up before subsequent fitness exercises. It's all about progressing and adaptation. We can see a similar progression with push-ups. We can start with wall push-ups or floor push-ups in a rehab setting, focusing on pain-free range of motion and control. As patients progress to the fitness settings, we can introduce the bench press with increasing load, focusing on power and strength. Again, those initial floor push-ups can still serve as a dynamic warm-up before subsequent fitness exercises. As physios, we must continually learn to adapt our approach based on patient responses and new knowledge. Our goal is to facilitate seamless transition from rehab to lifelong fitness by understanding how to apply the principles of movement preparation across the continuum. By doing so, we can empower patients to take control of their fitness journey and achieve their goals. Now, my favorite dynamic warm-up routine may or may not include some light cardio. Some days I'm feeling it, some days I'm not, but every workout begins with mobility exercises. If I'm on the stability bike or treadmill, I start by opening and closing my hand with finger flexion, progressing to open fist, closed fist, and finally, full fist closure with wrist flexion, followed by hand opening with wrist extension. This pattern of progression from early entry to mid-level to high level is a continuum that I find effective. The goal here is to move almost all the joints through almost all planes of motion, especially rotation at the shoulder and the hips. I avoid neck circumduction to prevent irritation of the facet joints and nerves. I also skip trunk side bending because it's not a functional motion. Remember, you can argue with me in the comments below, but like always, pain-free motion is the rule. In the upper extremity, I have 3 motions to get everything moving. Easy peasy lemon squeezy. First, I do a horizontal abduction adduction swings, adding pronation and supination. It's easy to add neck side bending. So we have entry-level versions, progressing to mid-level versions, culminating in a higher level version. Second, I move on to shoulder rotation, starting with low amplitude, including finger flexion and wrist flexion. I also add neck rotation to this. So we have an entry-level version, progressing to a mid-level version, and culminating in a higher level version. Third, I do shoulder elevation. I've chosen shoulder abduction because at the end range of flexion and abduction, they both end up in the same place. I'd also add neck flexion and extension. So we have an entry-level version, we have a mid-level version, and we have a higher level version. For the lower extremity, I have 6 moves. Maybe you have more economical routine, but I like I said, these are the ones I like to be functional. I've tried to progress from weight bearing to balance movements. First, for hip flexion, I do front kicks, adding dorsiflexion. This is a nerve flossing motion, starting with the seated long arc quad exercise, progressing to standing front kicks. This is similar to the straight leg raise test flipped upside down. I progress through entry-level versions. I have a mid-level version holding on, and then culminating into a higher level version. Then for knee flexion, I do butt kicks, adding plantar flexion. This is another nerve flossing exercise. This one is similar to the prone knee bending test. Again, I progress through an entry-level version in sitting, standing with support for mid-level, and culminating into a higher level version. Third, I have hip abduction and adduction. I do lateral movements, adding hip rotation. This combination helps loosen up the hips and prepare them for more complex motion. Entry-level version, progressing to a mid-level version, culminating into a higher level version. After that, for hip rotation, I focus on simple hip rotation movements. While cardinal play motions can be robotic, I find that rotations are easier to implement for more effective loosening up of the joints. I have an entry-level version, I have a mid-level version, and I have a higher level version. For trunk flexion and extension, I use variations of the famous yoga poses. These movements help loosen up the spine and prepare for more complex motions. I have an entry-level version, I have a mid-level version, and I have a higher level version. Finally, for trunk rotation, I do a lateral lunge variation. You may argue this isn't the best use of trunk rotation, but this is how I like it. For these movements to help loosen up the spine and the hips, prepare them for more complex motions. Entry-level version in sitting, supported standing in the mid-level version, and then culminating into a higher level version freestanding. So like 10 reps of each. This will take you a couple minutes to run through, and it's a couple minutes well spent. That's all the juice I've got for now about the physio context of dynamic warm-ups, movement prep, and controlled articular rotation, CARS, in rehab and in fitness. I hope it helps. Let me know what your favorite warm-up moves are and what you like about them and who they're good for. Write about it in the comments. Bonus if you use the word continuum. My 2 books are now available at Amazon. What They Don't Teach You About Documentation in Physiotherapy School, a short how-to manual for successful daily note templates, and From Injury to Recovery Through Exercise, simple functional exercise progressions for physiotherapists to restore lifting, standing, walking. Thank you for your support. Let's have fun watching this neat video together. And by subscribing, you'll be among the first to know when new exciting content arrives. Thank you.